So, welcome back to the deep dive. And, we know you're here because you want that really rigorous, aha-filled exploration of complex topics.
Right, without all the overwhelming medical jargon.
Exactly. And today, we are tackling a topic that, honestly, it sounds terrifying, but from a nursing perspective, it's actually this incredible masterpiece of clinical plumbing and physics.
It really is. We're talking about heart failure.
Yeah.
Specifically, what happens when the body's pump just, falls behind.
Right. And our mission for you today is to understand how to spot the really distinct signs of left-sided versus right-sided failure and why our basic human intuition about how to fix this broken pump has historically been completely dead wrong.
Yeah, but before we even get into all that plumbing, we have to dismantle the biggest misconception right out of the gate. Because when people hear heart failure, they usually panic.
Right, they think cardiac arrest, like flatline.
Exactly. But heart failure does not mean the heart has stopped beating.
Oh, thank goodness.
Right. I mean, the heart is still beating, sometimes at a totally normal or even like an elevated rate. Heart failure is a clinical syndrome. It's not a single disease.
So it's more like a broad category.
Yeah. It just means the heart cannot pump enough blood to meet the body's demands. Or, and this is crucial, it can only meet those demands by abnormally jacking up the pressures inside its own chambers.
Okay, let's unpack this. Because the way we understand this broken pump has fundamentally changed over the years, right?
Oh, massively. The definition of heart failure has been this huge moving target.
Which makes sense. I mean, historically, say, back with the 1971 Framingham criteria,
Uh-huh.
doctors essentially diagnosed this by looking for the biological equivalent of a flooded basement.
That is a great way to put it. Yeah, in the 70s, it was purely about clinical signs. You'd literally go down a physical checklist.
Like, are the neck veins bulging out?
Right. Are the ankles swelling up? Can you hear crackles in the lungs with a stethoscope? It was entirely based on the visible physical backup of fluid.
It's like diagnosing a broken car engine in the 70s, Like, you see thick black smoke pouring out of the tailpipe, so you know it's broken.
Exactly. You didn't need a computer to tell you it was broken.
But today, that's changed. If you look at the 2021 universal definition from the Global Cardiology Societies, it's completely different.
Yeah, they changed the rules. Now, you still need those physical symptoms, but it requires objective evidence to back them up.
Meaning we're plugging the computer into the dashboard now?
Pretty much, yeah. We are looking for structural imaging or elevated biomarkers in the blood, like natriuretic peptides.
And I love this part because these peptides are essentially the heart's own internal distress signal.
That's exactly what they are.
Like when the actual muscle tissue of the heart gets physically stretched out from too much fluid pressure, the cells literally release these hormones into the blood.
Right. And finding that objective evidence became so important because the old 1971 criteria, the tailpipe smoke, was missing a huge chunk of patients.
The invisible patients.
Yes. The old checklist worked perfectly for what we call reduced ejection fraction cases.
Wait, let's quickly define ejection fraction for the listener because this is kind of the mathematical core of the whole thing.
Sure. So a healthy heart doesn't empty out 100% of its blood with every single beat.
Which is wild to think about.
It is. When your left ventricle squeezes, it only pumps out roughly 55 to 70% of the blood inside it. That percentage is your ejection fraction.
Okay, so 55 to 70 is normal.
Right. But in a classic failing heart, the kind with those dramatic 1971 symptoms, the muscle is weak, it's thin, it's floppy.
It just barely squeezes.
Yeah, so the ejection fraction plummets to like 35 or 20 or even 10%. That is heart failure with reduced ejection fraction, or HFrEF.
HFrEF, okay. But relying just on that floppy muscle model entirely missed a parallel condition, which we now call HFpEF.
Heart failure with preserved ejection fraction.
Right, and so the math here looks completely fine.
Exactly. The heart squeezes normally. The ejection fraction is 60%, but the underlying cellular architecture is totally messed up.
Because of things like chronic high blood pressure, right?
Yes, severe hypertension over years and years. The heart muscle bulks up to pump against that high pressure, gets really thick, and over time, this fibrotic tissue, collagen, gets deposited into the muscle.
So it goes from being this nice pliable balloon to like a stiff, hardened leather pouch.
That is the perfect analogy.
It squeezes just fine, but it cannot relax.
So it's a filling problem, not a squeezing problem.
Exactly. The walls are so stiff that the chamber can't expand to let enough blood in between beats. And here's the so what for you listening.
Yeah, why does this matter?
HFpEF makes up roughly half of all heart failure diagnoses today.
Wow, half.
Half. So if you are only looking for a weak pump, you are entirely blind to 50% of the people suffering from this syndrome. Okay, so if half these patients have a weak pump and half have a perfectly strong but stiff pump, how do we end up with the same catastrophic fluid backup? Like, where does the physics of this actually break down?
To understand that mismatch, we actually have to go way back, long before ultrasounds could show us a stiff ventricle.
Oh, you're talking about dropsy.
Yes, back in ancient Egypt and Greece, physicians saw this severe, unexplained swelling of the legs and abdomen, and they just called it dropsy.
And they had no idea the heart was the actual problem.
None. They were just looking at the end-stage fluid backup.
But wait, if they didn't know the heart was involved, how did they eventually stumble onto a heart medication?
Just meticulous observation. In 1785, this English physician named William Withering heard about an old folk remedy for dropsy that used the foxglove plant.
Which is pretty toxic, right?
Very. But he didn't know the mechanism. He just conducted these rigorous clinical studies, treating over 160 cases with a foxglove extract called digitalis.
And we still use derivatives of that today, like digoxin.
We do. It's amazing.
I mean, now we know it messes with the sodium-potassium pumps on the heart cells, right? It lets calcium build up inside, which forces the muscle to contract harder.
Right, but understanding the true physics of why the heart was failing in the first place, and why just forcing it to squeeze harder isn't always the right move, that took another century to figure out.
Okay, so bring us to the frog hearts.
Right, so 1895, this German physiologist Otto Frank is isolating frog hearts.
Uh-huh.
And then a few years later, an English physiologist, Ernest Starling, sets up these dog heart-lung preparations.
And Starling basically attached a fluid reservoir to the dog hearts, right?
Yeah, he had a dial. He
Okay.
could manually increase the volume of blood flowing into the heart and literally watch the cardiac output respond in real time.
And what they found is the Frank-Starling law, which I always picture this like a rubber band.
I love the rubber band analogy.
Because, on a microscopic level, heart muscle is just protein filaments, actin and myosin. They grab onto each other and pull. So if you stretch a rubber band back just a little bit, it snaps back well. If you pull it back further, those protein filaments slide into perfect alignment and it snaps back much harder.
But, and here's where Starling kept turning the dial, he kept adding fluid, and he found the inflection point.
Where you stretch the rubber band way too far.
Exactly. You pull it too far, and the filaments literally lose their physical grip on each other.
The rubber band gets all warped and loose.
The output plateaus, and then it just plummets. This is the failing heart. It operates on the descending limb of that Starling curve.
So extra blood volume no longer buys you extra pumping force. The pump just cannot move the fluid forward.
And if it can't go forward, it has to go somewhere.
It pools upstream.
Yes. And because the human heart is a two-sided pump arranged in series, where that blood pools dictates the entire clinical picture.
This is the crux of it for nurses, right? Left-sided versus right-sided failure.
Exactly. They feed totally different vascular territories. Let's do the left side first.
Yeah.
The left ventricle's only job is to take fresh, oxygenated blood from the lungs and blast it out to the body.
So if the left ventricle is that overstretched, warped rubber band, it fails and the blood backs up into the lungs.
Right, the pulmonary circulation. Left-sided failure causes a respiratory crisis.
Because the pressure builds up so high that fluid physically pushes out of the capillaries and floods the air sacs.
Floods them. The primary sign you'll see is dyspnea, shortness of breath when they exert themselves.
But the really fascinating part is how that shortness of breath changes when they just change position, like orthopnea.
Right, orthopnea is breathlessness specifically when lying flat.
Because gravity plays such a huge role here.
A massive role. During the day, when you're standing, gravity pulls all that excess fluid down into the bases of the lungs or into your legs.
So the top parts of the lungs are dry and can still exchange oxygen.
Yes, but when the patient lies flat in bed at night,
Gravity is neutralized.
exactly, a liter or two of fluid that was sitting in their legs suddenly shifts back into the central circulation. It rushes the heart, overloads that poor left ventricle even more, and the fluid just spreads evenly across the entire surface area of the lungs.
Oh, wow. So they literally feel like they're drowning?
Because internally, they are. They have to prop themselves up on 3 or 4 pillows just to sleep.
And in severe cases, you get PND, right? Paroxysmal nocturnal dyspnea, where they wake up gasping for air in a total panic.
It's terrifying for the patient. And if you listen to their back with a stethoscope, you hear crackles or rails. It literally sounds like fluid bubbling in the airways.
And you also might hear that extra heart sound, the S3 gallop,
Yes.
which the acoustic physics of that are so cool. It's like a lub-dub-dub, and it's literally the physical sound wave of fresh blood crashing into a ventricle that is already bloated and overfilled.
Spot on. So that is the left side. Flooded lungs. Now let's look at the right ventricle.
Okay, so the right side's job is to receive the depleted blood from the body and pump it into the lungs to get oxygen.
Right. So if the right side fails, the backup goes in the exact opposite direction.
It backs up into the systemic venous system, basically the whole body.
Yes, every single vein trying to drain blood back to the heart gets congested. The signs of right-sided failure are the ones you can visually diagnose from across the room.
Like JVD, jugular venous distension.
Exactly. The neck veins visibly bulge out like ropes because the venous pressure is so incredibly high.
And the organs just take a massive hit, right? Like the liver.
The liver is heavily vascularized, so when those veins back up, the liver becomes entirely engorged with blood. The capsule around it stretches.
Which causes hepatomegaly, this enlarged, really tender liver.
And if you press firmly on that swollen liver, you trigger what's called the hepatojugular reflex. You physically force more of that trapped blood up into the neck, and you can watch the jugular veins bulge even further.
Wow. And just like in the lungs, when the pressure in the body's veins gets high enough, fluid just leaks out into the surrounding tissue.
Yes, you get dependent peripheral edema.
Like those severely swollen ankles.
Exactly. Pitting edema in the ankles and calves.
Yeah.
Or, if the patient is bedbound, the fluid pools in their sacrum.
And in the really advanced stages, fluid weeps into the abdominal cavity, which is called ascites. Plus, you see this really rapid weight gain.
Right, but here is the big twist.
Oh, right, because there's a huge clinical paradox here. If the left side exclusively drowns the lungs and the right side exclusively drowns the liver and the legs, how do we end up with patients who have both?
Right, you walk into a room and a patient has bubbling crackles in their lungs and severely swollen ankles.
How does that happen?
You just have to follow the plumbing loop. The single most common cause of right-sided heart failure is left-sided heart failure.
Wait, really? The left breaks the right?
Yes. The chronically high pressure transmits backward, the left side fails, pressure builds up in the lungs, so now the lungs become this high-pressure zone.
And the right ventricle isn't used to that.
Not at all. It's
Yeah.
used to pumping into a very soft, low-pressure lung environment. Suddenly, it has to shove blood against a literal wall of resistance.
So it bulks up, it tires out, and it fails too.
Exactly. The cascade completes itself. You get biventricular failure.
Okay, so seeing a patient in this state gasping for air, their organs swelling, the most logical, intuitive human response is to look at that weak pump and say, let's give them a drug to force this pump to squeeze harder.
It is the most intuitive thought in the world.
But medical history showed us that following our intuition here is literally deadly.
It's one of the most sobering lessons in modern cardiology. Think back to the PROMISE trial in 1991.
This is the trial with milrinone, right?
Yes. Milrinone is an oral inotrope. It chemically bypasses the heart's natural regulation to force calcium into the cells. It commands the muscle fibers to snap together with immense force.
So they were essentially trying to fix the overstretched rubber band by chemically forcing it to act like a brand new one.
Exactly. And in the short term, it looked fantastic.
Monitors looked great, right?
The hemodynamics improved, the patients felt better, cardiac output increased.
But the final result of the trial was a staggering 28% increase in mortality.
They were dying significantly faster.
Because they were forcing a failing, energy-starved muscle to do way more work.
You are whipping an exhausted, starving horse. It will sprint for a mile and then it will just collapse. The drug raised the heart's oxygen demand so high, and that massive influx of calcium provoked fatal arrhythmias.
Wow.
It proved that treating a symptom, the weak squeeze, is fundamentally different from treating the underlying disease process.
Which brings us to the exact opposite phenomenon, the beta blocker reversal.
Oh, this is fascinating. For decades, beta blockers were strictly banned for heart failure.
Because beta blockers literally slow and weaken the heart's contraction.
Right, and the logic seemed bulletproof. If a patient's pump is already failing, giving them a drug that deliberately weakens the contraction even further sounds like malpractice.
Wait, yeah. How did doctors in the 90s even justify testing that on a patient?
They had to look beyond the mechanics and look at the broader biology. See, when cardiac output drops, the brain senses a drop in blood pressure.
And the brain panics.
Total panic. It activates the sympathetic nervous system, flooding the body with adrenaline. The body basically thinks it's bleeding to death, so it constantly whips the heart to work harder.
The body is making its own internal milrinone. It's whipping itself. Yeah.
Exactly. And chronic sympathetic overdrive is intensely toxic to heart muscle cells.
Yeah.
It causes them to literally die off.
But trials like MERIT-HF prove that if you give beta blockers, you block that adrenaline.
Yes, you shield the heart cells from that toxic bath. Yes, the pump gets slightly weaker for the first week or so, but over months, shielded from the whipping, the muscle actually begins to heal.
It reverses the damage.
Beta blockers drastically reduced mortality. It was a complete triumph of data over intuition. They are now an absolute cornerstone of therapy.
Okay, so we figured out how to save the floppy, weak hearts. But what about the other half? The HFpEF patients.
The stiff hearts.
Yeah, the ones that squeeze fine but can't relax.
Well, the HFpEF debate was incredibly frustrating. For 20 years, the drugs that saved the weak hearts like beta blockers failed to show major mortality benefits for the stiff hearts.
Because the mechanism is just totally different. A stiff, fibrotic ventricle doesn't care if you shield it from adrenaline. It physically cannot stretch.
Right. But we recently had this huge surprise success with SGLT2 inhibitors.
Like in the Emperor Preserve trial. And these were originally diabetes drugs, right?
Yes, they block a protein in the kidneys to force the body to pee out excess glucose.
So how does peeing out sugar help a stiff heart muscle?
When the sugar goes into the urine, osmotic pressure forces water to follow it. So it acts as this profound, gentle diuretic. It slowly drains the excess fluid volume out of the blood, reducing the pressure on that stiff ventricle.
Oh, wow. And it doesn't trigger the body's panic responses.
Exactly.
Hmm.
Plus, researchers think it alters the metabolism of the heart cells to burn energy more efficiently. It was a massive breakthrough.
Okay, so why does all of this matter to you listening today? Well, thanks to the Framingham Heart Study, we know the lifetime risk of developing heart failure for a 40-year-old is roughly 1 in 5.
1 in 5. And with populations aging and more people surviving massive heart attacks, which leaves them with scar tissue, they live long enough to develop chronic heart failure later.
It is a massive driver of healthcare spending, which brings us back to the nursing angle and self-monitoring.
Yes, 30-day hospital readmissions are a heavily tracked metric.
Okay.
Because this decompensation, it's often entirely preventable.
Right. Catch the supply and demand mismatch before the rubber band stretches too far.
Exactly. And something as simple as tracking daily weight is revolutionary. A rapid weight gain of just a few pounds in 24 hours is not fat.
It's fluid.
It is the real-time hydrostatic failure of the right ventricle. It signals fluid retention days before the patient ever feels breathless.
So the clinical team can just adjust their diuretics and keep them out of the hospital. Okay, so before we wrap up this deep dive, I know you have one final provocative puzzle to leave our listeners to ponder on their own.
I do.
Oh, yeah.
And it ties back to everything we just discussed. So we learned that the modern 2021 definition relies on objective evidence, right?
The natriuretic peptides, the heart's internal distress signal.
And those peptides are released when the heart muscle is physically stretched out.
Yeah, stretched by the excess fluid.
But we also learned that half of all heart failure patients today have HFpEF,
The stiff hearts.
a severely stiff fibrotic heart that doesn't relax or stretch well at all.
Oh, wait.
Right. So if our gold standard biological marker requires a stretching muscle, how many patients with uniquely stiff hearts might this diagnostic system still be struggling to capture?
Wow, that is a brilliant question. We might still be missing people. Well, something for you to explore on your own. Thank you for joining us on this deep dive into the broken pump. We'll see you next time.